Hi, introducing to the next emergency series of Let's Talk Health, an initiative by Star Hospitals. Today we're going to be talking about trauma, and specifically we're going to be focusing on orthopedic trauma. I'm Dr. Rahul Katta. I'm the group lead for emergency services at Star Hospital. So I'm a fellow of the Royal College and I deal with most aspects of emergency care as well as pre-hospital care. And with us today, we have Dr. Praveen Mereddy to talk about orthopedic trauma with us.
Hello, my name is Dr. Praveen Mereddy. I'm one of the senior consultant orthopedic surgeons working at Star Hospital, Nanakrampooda. Basically, I'm India and UK trained orthopedic surgeon with more than 24 years experience. And I have done my fellowship in trauma and orthopedics in the UK from Royal College of Surgeons, Edinburgh. And we've relocated to India about 12 years ago. And ever since, we have been able to provide a multidisciplinary trauma care in whichever hospital we worked. And in the last 18 months, we have been working at Star Hospital, providing the same.
Talking about trauma, one of the things that we definitely need to focus on most often than not is the very magnitude of trauma that we deal with, particularly in India. If you look at present statistics, the unfortunate truth is that we actually have one of the highest mortality when it comes to trauma.
Absolutely.
And this is a challenge that we definitely need to address. Two ways of addressing this is one is on the pre-hospital end, where we deal with trauma at the site of the accident itself. And two, which is definitely quintessential for the mortality and morbidity of a patient, is what we do in the hospital too. And that's what we're going to be focusing on during this talk. So whenever we talked about this, and Dr. Praveen Mereddy mentioned this term too, he said multidisciplinary team involvement. So how important is multidisciplinary team involvement when you're talking about trauma care?
No, it is absolutely vital and very crucial for all the members of the team to be present whenever a multiply injured patient comes to the emergency. For two simple reasons: that you don't start examining from head to toe by one person. Multiple people will be assessing the patient at the same time, resuscitating him, and then treating him or her at the same time. So I think that is why, because the initial golden hour treatment is the key for the success or the survival of the trauma or the injured patient. So I feel it is something which we have picked up from American Academy of Orthopedic Surgeons through ATLS, which is Advanced Trauma Life Support protocols, which have been well established in the West, but now we have been implementing in the in India in the last 12 to 15 years as well.
That's very true. I mean, one of the biggest challenges that we have when we deal with trauma is we deal with it in isolation. Every single department deals with it in their own right. So a urologist is focused on any injuries with the urological system. The orthopedicians are mostly involved with respect to the bones. Then you have the cardiothoracic team, which is worried about the chest. If we deal with this in isolation, then only a single disease process or a single injury profile is addressed at the same time, which is the reason why we are talking about the concept of multidisciplinary team involvement. If you look at how we want to deal with it differently, particularly at Star Hospitals, what we tend to do is introduce the concept of a trauma call. Whenever we have a patient who is a polytrauma, we put out a trauma call out. And what happens here is very specific. We get the subject matter expertise down onto the floor, and sometimes even before the patient actually arrives to the floor. This way you have the orthopedicians, you have the surgeons, along with the emergency team at the bed as soon as the patient is there. You do the primary survey once, which roughly takes about 2 minutes, and sometimes if you're doing interventions, may take about 10 to 15 minutes. And by the end of this, you understand the entire injury profile and you already have a plan of care. As Sir mentioned, the first hour is very crucial. And in fact, if you look at recent studies, even the first few minutes are absolutely crucial. So what we do here makes all the difference, and the faster we do it, the better it is. So single primary survey, a clear injury profile, and a clear plan on how to deal with this patient, and the sooner we do this, is absolutely quintessential when it comes to the outcome of this patient. And it's exactly what we try to focus on at Star Hospitals.
Absolutely. So it is, as Dr. Rahul Katta clearly mentioned, that we go step by step, but at the same time, all the team members will be acting on the patient and diagnosing the problem and also resuscitating at the same time, because an airway could kill the patient, airway problem could kill the patient within seconds, whereas the circulation problem can wait. So it's a stepwise manner which we go from the airway, breathing and the circulation, and then you look for neurological deficits in the same way. So this is a system, well-established system, it's well-oiled machine which we are following, and that has given great results in our experience.
That's very true. There is no point in reinventing the wheel. This is something that is quite well established, unfortunately not practiced well enough. So doing simple things right and doing it often enough makes a phenomenal difference when it comes to outcomes.
Absolutely.
Particularly with respect to polytrauma, and when it comes to India, what are the challenges that you foresee?
So most of the time the polytrauma patient goes to the nearest hospital like anywhere else in the world, and if the nearest point of contact, the first hospital where they go to, if they did not have adequate resuscitation, that's where the problems start. So by the time the patient comes to us, patient is usually either unconscious or not responding, and he's been in hypovolemic shock. When we say hypovolemic shock, he's in real shock that you need to treat immediately with blood transfusion and IV fluids simultaneously. So this is the situation which we face, because by the time they reach, say for example, they are coming from a 6 to 8 hour distance place, if they are coming all the way, if they have been adequately resuscitated and somebody is accompanying who can deal with the fluid management, that would be ideal. But unfortunately, we are not in a ideal scenario. So we do come across patients who have been not resuscitated well and who are about to die literally. And sometimes we are lucky to save them, but sometimes the ball has missed and then they will be in almost a dire straits situation, and then we may lose them also. So the important point which we want to emphasize here is the initial resuscitation. Whoever sees the patient is the key, and the same thing is continued at hospital, and the pre-hospital care is already there in the system, but again it's not well established. We are trying our best to educate a lot of other hospitals and the ambulance team as well, and Dr. Rahul Katta and his team has been doing a great job on this.
What Sir said, that particular sentence is extremely important. When you're working on the physiology of the patient, early resuscitation is the key. The difference is fairly straightforward. It is not the broken bone that's actually going to kill this patient.
Absolutely.
In fact, most often than not, whenever we are dealing with trauma, we tend to focus only on the injury. But what is more important is actually the physiology of the patient. Very simple here. You need to make sure that the heart rate is appropriate, the blood pressures are at least at a minimum mark to perfuse all of the organs. So you need to maintain that systolic blood pressure at least above 90. So there are a few certain requirements of how the human physiology is that has to be maintained. And that actually has a bigger influence on the outcomes than anything else. In fact, most complex polytrauma patient, we don't address the injuries immediately. Our primary focus is always on maintaining the physiology, trying to get that heart rate at an appropriate rate, trying to get that blood pressure at an appropriate pressure. That is the key role of addressing complex polytrauma initially, because fixing the bones and definitive surgery comes later. Initially, what we need to do is damage-controlled resuscitation, which is basically getting that blood pressure up to a physiological parameter that is enough to get that blood supply to all of the organs. And that is why having a multidisciplinary team involvement is so important. And this, as Sir had stated, starts pre-hospital. That starts at the ambulance itself and continues through the rest of the hospital. That's what makes a difference when it comes to outcomes. With the newer advances with respect to trauma care, is there anything recent that you think has had a significant influence with respect to how we deal with trauma patients?
No, absolutely. So the simplest thing what we have come across, and it has been implemented in the last 10 to 15 years, is again use of a simple pelvic binder or a blanket or a bed sheet to just tie the pelvis or close the book, what we call as the in an open book type of pelvic fracture. Now this is why so important it is, because most of the bleeding in a pelvic fracture occurs from what we call as the pelvic veins, which are in the retroperitoneal region. So if you just close the book, anybody can do this. It's not on the tummy, but just below the tummy at the level of the hips. If you just tie and this has been very strictly followed by most of the district hospitals and before they transfer the patient. That is the most important thing. And then again, getting the blood and starting the blood and blood products very early. These have been well proven, starting from fresh frozen plasma and packed red blood cells along with IV fluids. So 1:1 ratio, we have been able to do that. I think that is from the resuscitation point of view.
Yes.
And then pelvic binder point of view. This has definitely saved many lives in the early golden hour.
This is very true. Just like how bystander CPR has had a massive influence when it comes to outcomes of patients who are in cardiac arrest, very similarly, initial resuscitation and how you go about resuscitation makes all the difference when it comes to trauma. From the get-go itself, making sure that you have a good airway, immobilization, control of bleeding, applying a pelvic binder to decrease the amount of bleeding, all of these are extremely important. Done early can save lives. And that is the reason why we need to focus on this. Simple stuff done right makes all the difference. Particularly with some of the recent studies that have come across too, as you mentioned, resuscitation is the key, and particularly here there's an increased focus on replacing blood for blood and not using a lot of fluids.
Yes.
And I think that's a very important point that you have mentioned too, and that is another reason why it's very important for people who are experiencing trauma to go to the appropriate hospital where they have the key resources, particularly easy accessibility to blood products so that they get the right kind of care.
Dr. Rahul, I was just wondering, do you have any specific plans? How do we get this state-of-the-art facility kind of care in an ambulance setting itself? And how do you receive a patient? Do you have anything like a special equipment in your ambulances? And where are you going to, how they are going to get access to these ambulances? Do you have any particular plan?
Thank you for asking that question. One of the fundamental challenges that most people have is access to good emergency care.
Absolutely.
And particularly access to good ambulances. Because most often than not, forgive my language, the truth is it is a scoop and run. So essentially they grab the patient, they put him in the back of the ambulance,
yes,
and they go for it and they go to whichever hospital is close by. But there is no care that is actually delivered en route in the ambulance. And it's quite a massive challenge. The truth is this, I'll talk about a very personal story here itself. I had a friend of mine who was about 21 years of age. This was close to about 13 to 14 years ago.
Right.
She met with a road traffic accident on one of the highways in Bangalore. And then immediately she was put on the back of an ambulance, taken to the closest hospital.
Right.
Unfortunately, the hospital that was close by did not have any ventilators, so they had to take her again to Apollo where I was working. And unfortunately, by the time she reached me, we realized that she had unfortunately died.
Oh my God.
I was under the impression at that point that this was probably a consequence of polytrauma or a significant injury, and that's why this happened.
Right.
Later, once a postmortem was done, we realized she had lost consciousness. The truth is she did not have significant injuries. What she lost was her airway. So all they had to do is protect her airway. A simple flexion of the neck, provided it is safe, would have actually saved her life. And this is exactly why I meant simple stuff done right would have made a phenomenal difference. So to address this particular need of pre-hospital trauma systems, what we are doing right now is very soon we are looking at executing at least 14 ambulances across the entire city, where we are placing it based on what the data says accidents tend to occur, and that's the reason why we are focusing on these accident-prone areas. And this ambulance is going to be an advanced trauma life support ambulance, which has everything that you would probably need. As I mentioned earlier, you would need immobilization, so you have a spine board. You also have blocks on both sides. You have cervical collars, initial fluids for any resuscitation that might be required. So all of these would be there in the ambulances.
That's great.
And these 14 ambulances are going to be spread apart.
Fantastic.
Another important factor is there's no point just keeping these ambulances unless you have the expertise to use it.
Use them.
So what we are also going to do is make sure that we have paramedic cover for the
These
entire
ambulances.
24 hours, 7 days a week, so that we not only have the equipment we need, but we also have the personnel who know how to use this.
Fantastic.
For the next set of weeks, we're going to be focusing on training these individuals so that they are trauma ready. And then we're going to be pushing this out to the city of Hyderabad. And I think this would make a phenomenal difference.
Definitely, I think that's really great news, and all the best to all of us for the same.
So the idea is this, ladies and gentlemen. Trauma care starts at the site of the accident. And anytime you spot a trauma, what you would need to do is call for help. This could be either 108, and if you're closer to any of the star hospitals, you can call the number that is being displayed right now and access emergency care. So our promise is, as far as Star Hospitals is concerned, you will receive the right expertise, not just at the hospital, but at your doorstep, wherever this incident has occurred. So trauma care starts always at your doorstep. Thank you all for joining us on this series of Let's Talk Health, the emergency series, making sure trauma care is available wherever it occurs. Thank you.
Thank you.